Hola, buenas noches. Bienvenidos a la quinta sesión académica de Somera. Es muy grato para mí estar el día de hoy con ustedes. Soy José Hinojosa, secretario de Somera, y es un honor también estar aquí presentando al doctor David Shultz. Él es investigador clínico del Departamento de Radiooncología del Centro de Cáncer Princess Margaret. Es profesor asociado del Departamento de Radiooncología de la Universidad de Toronto y también director de investigación clínica de radioterapia. El doctor David nos va a presentar el tema de Sbrt en Columna, a quién, cuándo y cómo. Welcome, Dr. David. It's such a honor to be with you today, and please go ahead.
Thank you very much. Thank you very much for inviting me to talk. And I'm sorry that I cannot deliver this talk in Spanish, but
Next time.
Unfortunately, I'll have to do it in English, but I know that you'll translate for me, and I appreciate that. So I'll begin my talk. I'm just, Carla, I don't seem to have control over my slides right now. Am I doing something wrong?
Sí, no, necesitamos regresar, por favor, al principio. Estamos adelantando.
I am just trying to control them. Bear with me. Before I had control of the slides, but right now I don't. So.
Okay.
Okay. Okay, good. Now we're at the beginning. Perfect.
Okay, thank you.
Thank you. Okay. So today I'm going to talk about spine stereotactic body radiotherapy, which is one of the things that I perform at Princess Margaret. I'm going to talk about what it is and why we use it, how we use it, and when we use it. So, okay, I want to advance my slide. Hold on. Okay. So what is paraspinal stereotactic body radiotherapy? And how is it different than conventional palliative radiotherapy? So spine Sbrt, that's stereotactic body radiotherapy, is a technique that we use to treat mainly for painful metastases within one of the vertebral bodies. So if a patient has typically metastatic carcinoma, and they have a metastasis in their vertebral body, that can be treated obviously with conventional radiotherapy, typically something like 20 gray and 5 fractions, or 30 gray and 10 fractions, or 8 gray and 1 fractions, using either a single beam, radiation beam from the posterior, or 2 beams, an anterior and a posterior beam. And that would result in a dose distribution like you see on the top image here, with radiotherapy generally treating the entire vertebral body, and then of course also delivering dose to the bowel that's anterior to that. What stereotactic body radiotherapy does essentially is it delivers dose in a conformal way to treat only the vertebral body. And there are several technologies that help us do that. One is that the patient is immobilized, and that can be done in a variety of different ways. But basically, the patient is made to be in a rigid position where they cannot move. And obviously, there is image guidance used, and that image guidance is high precision and utilizes things such as a 6 degree of freedom couch, so that the patient can be rotated in all 6 degrees to match, so that they match the position they were in when the radiation plan was made on their radiation planning CT. And because of these things, and because of the highly conformal way in which the radiation dose is delivered, it allows us to use increased dose per fraction. And so that in essence is what Sbrt is. It's just delivering very high doses of radiation in a highly conformal way to a defined area. So that's really what the what is. So if we're to compare stereotactic body radiotherapy to conventional radiotherapy, we can do so on the basis of several different categories. So, for example, of the two, conventional radiotherapy is less resource intensive. And what I mean is that it takes less time to plan. The radiation planning is less complicated. You don't need the degree of immobilization that you need for SBRT with conventional radiotherapy. So if you're just comparing the two, conventional radiotherapy is a better technique in terms of resources. It takes less time to treat. You're less likely to miss subclinical tumor with conventional radiotherapy, only because you can treat a larger area. Generally speaking, you can treat a larger area with conventional radiotherapy. So if a patient has several vertebral bodies that are involved with cancer, it's generally better to use conventional radiotherapy as compared to SBRT because it's safer. And when you treat a larger area with spine SBRT, you run a greater risk of toxicity. So the risk of serious injury is worse with SBRT compared to conventional radiotherapy. And by that, I just mean that because you're using higher doses per fraction, you can, if you're not careful, cause something like a spinal cord injury with stereotactic body radiotherapy, which you really can't do with conventional radiotherapy because of the doses that are used. So 20 gray and 5 fractions, for example, will not injure the spinal cord, provided the spinal cord hasn't been radiated before. But with SBRT, if you do not align the patient correctly, or if you deliver dose to the wrong area, you are using a high enough dose so that you will injure the spinal cord. Now, the thing is that really with SBRT, the risk of spinal cord injury is very small because most of the time it's done by people who are experienced, and we're all very careful in radiation oncology. And we basically, I think one of the hallmarks of our field is precision. So although the risk of serious injury exists, it's actually very rare if you are doing the procedure carefully. Now, SBRT, I think, does beat out conventional radiotherapy from the standpoint of the likelihood of local control. So because you're using a higher dose per fraction, the chances of controlling that tumor that you're treating is higher than with conventional radiotherapy. Likewise, pain control is better, and that's now been proven in a randomized clinical trial that you actually can, there's a higher likelihood of a complete pain response if you use SBRT, again, presumably because you're using a higher radiation dose. And in terms of retreatment, if a patient has had prior radiotherapy to the spinal cord, SBRT is in many ways superior to conventional radiotherapy, because if the goal is to deliver as much dose as possible without injuring the spinal cord, SBRT is perfect for that. So who benefits from spine SBRT? And this is not a straightforward question. It depends very much on who you ask, but I think the question can really be broken down into 3 categories. One is from a philosophical standpoint, meaning that SBRT is perhaps best for patients with oligometastatic disease, probably best for patients who are going to live more than 6 months, and that's based on things like are they going to live a long enough time so that the increased rate of local control is meaningful? And are they going to live in long enough time so that the benefits of SBRT are realized? Likewise, many would say that patients who are the best candidates for SBRT have a reasonably high performance status. And you also need to look at the natural history of the disease, meaning that if a patient is progressing through their cancer very quickly, they may not benefit from SBRT, whereas if it's been a slower progression, perhaps they will. But that's really philosophical. It's not proven. From a medical standpoint, I think personally, SBRT carries the greatest advantage for cancers which are radio-resistant, meaning that they don't respond as well to radiation as others do. And cancers which I personally consider to be radio-resistant include melanoma, sarcoma, renal cell carcinoma, hepatocellular carcinoma. I would also include colorectal cancer in this category, esophageal cancer. These are all cancers which in my experience, respond less well to radiotherapy than do things like, say, prostate cancer or breast cancer, which typically are more responsive to radiotherapy and don't necessarily require SBRT. Finally, SBRT may be most beneficial for patients who have some degree of epidural disease. That means that if they have epidural disease, particularly, again, if we're talking about a situation where it's a radio-resistant cancer, for me, I think SBRT carries a big advantage because that is a situation where you really want to control the disease. On the other hand, if there's too much epidural disease, SBRT may not be advantageous because it becomes difficult to deliver the dose you want to deliver while sparing the cord. So it's not straightforward. And then again, from a technical standpoint, patients who will benefit from SBRT typically have a well-defined treatment volume that is not, involving obviously their entire spine, but typically involving a few vertebral bodies at most. And that exact number is not written in stone. It may be 1, it may be 3, it may be 5, but probably not something like 10 vertebral bodies. For that, conventional radiotherapy is really probably more beneficial. So I mentioned oligometastatic disease, and in the oligometastatic setting, again, SBRT potentially offers better local control, better pain control. And for oligometastatic patients who are probably going to live a long time with their metastatic disease, or may live a long time with their metastatic disease, SBRT is really highly beneficial because it permits you to deliver a dose that will control a tumor locally so that that tumor doesn't become the problem over time, which can happen, especially now that we're in the age of targeted therapies where smaller tumors are well controlled with targeted therapies or with immunotherapies. If there's one tumor in particular that's going to become, the problem for that patient because it's going to cause pain or spinal cord compression, SBRT is highly beneficial. And in this, I sort of like to invoke a concept of thinking beyond the conventional palliative paradigm, where typically palliative radiotherapy is delivered to reduce pain. And if a patient doesn't have pain, there's no need to radiate. But if they do, there is. And here, sometimes we're not treating purely to reduce pain, but we're treating so that that lesion doesn't become problematic for the patient in the next 3 or 6 months. So it's thinking ahead and trying to be proactive. So let's talk a little bit about the evidence for where conventional radiotherapy may be inadequate. We know, or there's retrospective evidence that conventional radiotherapy, again, meaning something like 20 gray in 5 fractions, or 30 gray in 10 fractions, or 8 gray in 1 fractions, is not as effective for bulky paraspinal tumors. Bulky sort of would include a tumor with a lot of extra osseous extension or a lot of epidural disease. Those tumors are not as well controlled, really just because they're bigger and they're harder to control. There's more cancer. For bulky tumors, SBRT is highly effective, whereas for conventional radiotherapy, it's typically not. Also, as I mentioned earlier, SBRT is highly advantageous for patients who require reirradiation to an area where their spinal cord has already received a lot of radiation. And another reason to use Sbrt is because it offers better pain control. And again, that's been proven, and it's not only more effective, but probably more durable pain control that lasts for longer because you're completely ablating the tumor that's causing pain. And just to mention, the evidence for palliative radiotherapy, we know from many studies that it doesn't necessarily matter with palliative radiotherapy, if you treat 30 gray and 10 or 20 gray and 5 or 8 gray times 1, they all result in roughly equivalent pain control if you look very early on, say at 3 months. But we do know, even from studies that have looked at palliative radiotherapy, that, for example, 30 gray and 10 provides more durable tumor control than, say, 20 gray and 5 or 8 gray times 1, really just because it's a higher dose. And so there's evidence even from palliative radiotherapy or conventional radiotherapy that higher dose results in a more durable tumor control. Now, there's one thing that we need to talk about is spinal cord compression, because we, as radiation oncologists, spinal cord compression is something that we're often called upon to treat. And defining the role of Sbrt in spinal cord compression is a little bit tricky, in part because spinal cord compression per se doesn't have an exact definition. Some people would describe spinal cord compression as a situation as where the tumor is in contact with the spinal cord or maybe is indenting the spinal cord. Others would describe spinal cord compression as a situation where the patient actually has a neurologic deficit. If a patient has a neurologic deficit, then we know from the Patchell study, which was published 15 or 16 years ago, that that patient will benefit from surgery first, as opposed to radiotherapy, at least opposed to conventional radiotherapy. So a patient with cord compression should probably have a surgery first and foremost. And the decision of whether that patient gets surgery is based on a lot of factors. It depends on the surgeon and their particular criteria. But it's just to say that I don't think Sbrt replaces the need for surgery in spinal cord compression. On the subject of pain from spinal cord metastases is also not completely straightforward, because a patient can have pain in their back for a few different reasons, or a cancer patient can have pain in their back for a few different reasons. One is when the tumor in a vertebral body causes a fracture of that vertebral body. And when that occurs, typically the patient experiences what we call mechanical pain, which means that whenever they move, it causes pain. And that's because the fractured bone is basically causing stretching of the periosteum, or sharp edges of bone are touching the periosteum, and that causes pain whenever they move. And that type of mechanical pain does not respond particularly well to radiation, because radiation, of course, doesn't fix the fracture. And sometimes when I'm called upon to see a patient who's got pain in their back, and we know from imaging that they have a tumor somewhere in their spine, the first thing I try to assess is what is causing their pain. Is it mechanical? Is it a fracture? Or is it what we call oncologic or biologic pain, which is when there's not a fracture and the tumor is just causing inflammation and swelling that causes pain. That type of pain, that oncologic or biologic pain, responds very well to radiation. It also responds really well to steroids. So you can ask patients, well, what causes your pain? Is it when you're moving around, or is it when you're lying in bed at night that you feel the pain the worst? If a patient says, I have pain, it wakes me up from night, at night. It doesn't matter what I'm doing. It actually feels better sometimes when I'm moving around. Then I know it's biologic and I know it's going to respond really well to radiation. On the other hand, if somebody tells me they don't have any pain at all, unless they move, like they can sit in a particular position, they have no pain at all, then I know, okay, I need to call a surgeon because, you know, radiation is not what's going to make this patient feel better. Now, many times patients have a mix of both types of pain, to be honest. And so it's not straightforward what they need. And sometimes it depends on what's available, what is available immediately and what may be available in the future. So it's not always an easy decision, excuse me, but that can be helpful, at least in deciding what's the best thing for the patient in the immediate future. So there's something called the SIN score that you can use to determine whether or not a patient needs surgery. The SIN score was invented by spine surgeons, and it scores instability in the spine on the basis of where in the spine the tumor is, what type of pain a patient has, whether the lesion is lytic or blastic, and other things which you can see here. And then you determine the score. And if the score is greater than 12, that is a patient who probably needs to be evaluated for spine surgery. If it's lower than 12, then I think calling a spine surgery is not urgent. A spine surgeon rather is not urgent, and you can consider radiotherapy first, and then perhaps referring to a spine surgeon in the future if their spine becomes more unstable. Another scoring system which is helpful in describing a patient with a disease in their spine is something called the Bilski grade. And the Bilski grade is something that's used to describe how much epidural disease there is. And it basically goes a score of 0, 1, 2, or 3. Or sorry, yeah, a score of 0, 1, 2, or 3. 0 would be none. 1 would be tumor in the epidural space. And that can mean just a little bit, that's 1A. 1B means that it is now indenting the thecal sac, and 1C is when the thecal sac is indented to the point that is in contact with the cord. If the cord, the spinal cord that is actually in contact with the tumor and has changed shape, and of course you can only really see this on an MRI, then that's considered Bilski 2. And then Bilski 3 is when there's so much tumor in the spinal canal that you can't see CSF anymore. And that's Bilski 3, and that's typically a patient who's going to have neurologic compromise, sometimes, but not always. Bilski grade is just important because it really gets at the heart of what's challenging about SBRT, and that the more tumor there is in the spinal canal, the harder it is to control with SBRT. And that's because the spinal cord is, essentially sensitive to radiotherapy, and the amount of radiation that you typically need to deliver to control a tumor is more than what the spinal cord itself can tolerate. And so there's a balance there, and the balance is in your favor when the tumor is far away from the cord. And the more tumor there is adjacent to the cord, the less easy it is to control that tumor with radiation. So getting a little bit closer now to the how of this question of how do we do SBRT. The contouring for SBRT is really nicely defined in this paper from 2012. These are just consensus guidelines, really, but they describe how you should contour the vertebral body when there is tumor in it for SBRT. And it looks complicated, but it's really not. Basically, what it comes down to is, for example, if there's tumor only in the vertebral body, well, first, let me just say, because I don't think it's necessarily something that we all think about, is A vertebral body is, or sorry, a vertebral bone is divided into different compartments. One is the vertebral body, that's the biggest part. Then there are the pedicles immediately behind that. And then the posterior aspect of the vertebral body includes the lamina, the transverse processes, and the spinous process. And really with spinous SBRT, the consensus guidelines state that you target with your CTV the area where the tumor is, and then the two areas of the bone that are adjacent to that. So for example, if the vertebral body is where the tumor is, and it's only in the vertebral body, then you would contour as your CTV the vertebral body and the pedicles. So those are the two areas next to it that are at highest risk for microscopic tumor. And so I'll just show you a little bit about how I would contour a patient who had a vertebral body disease. So this is a patient I treated many years ago who had melanoma in the T10 vertebral body. And this here is what the GTV looked like. So usually when I'm contouring for spinous SBRT, I'll be using a planning CT scan and then a planning T1 weighted MRI scan and a planning T2 weighted MRI scan. And it's really the T1 weighted MRI. And this is a non-contrasted T1. That's very important because the contrast makes it actually a lot harder to see where the tumor is. The T1 shows me where the tumor is, and that's where the marrow, the natural marrow signal is replaced with this hypo intense or dark signal. So that's the GTV. So this GTV included the body and the pedicles. And then so therefore my CTV includes the body, the pedicles, and the transverse processes and lamina to look like this. Now, we always, of course, need to identify the spinal cord, and we do this by registering or fusing the MRI to the CT. So that's the spinal cord. And then we add a PTV. Now, how big the PTV depends upon what technology you're using to deliver the SBRT. We at Princess Margaret, we use a LINAC-based approach, and so we use a 2 millimeter PTV. The other elements that you're going to potentially add are things that, such as in this case, the esophagus, which would have been right anterior to that vertebral body, perhaps the liver, lungs. Sometimes the skin is actually at risk, especially for a tumor in the sacrum. So these are all other things that you would have to contour. And then when you get a radiation plan, so typically we would deliver 24 gray in 2 fractions. You evaluate that on the basis of the dose to the spinal cord or thecal sac, depending on what you're using as your organ at risk. We actually use what we call the spinal cord PRV, which is the spinal cord plus a small margin of 1.5 millimeters. You look at the dose to the esophagus. There's a constraint that we use for that, and the liver, the lung, and the skin. Usually, though, the biggest, obviously, the hardest thing to achieve is the spinal cord constraint. And then in the thoracic spine, it's usually the esophagus. And those are the two challenges. Of course, also, I should say that we look at coverage of the CTV and PTV as well. You can deliver SBRT in the postoperative setting as well. There isn't any prospective evidence for this, but there's many retrospective series from hospitals like Memorial Sloan Kettering and from the University of Toronto that have shown very good rates of local control with SBRT in the postoperative setting. It's more challenging to deliver SBRT in the postoperative setting for several reasons, including metal artifact and postoperative changes, but it's still widely done, again, particularly for radio-insensitive tumors. And there are guidelines now for contouring in the postoperative setting that were published 4 years ago. So this is just to show you some examples of how in the post-op setting, things can get complicated very quickly. So this is a patient who had metastatic colorectal cancer and had this L4 tumor. You can see that there was some vertebral body collapsed. He was in a lot of pain. To be honest, there was some mechanical pain associated with this, as well as some biological pain. There's not really any epidural disease here. There's some bowing out of the back of the vertebral body, but it's still contained within this ligament here, which is the posterior longitudinal ligament. This was actually a pretty good target at this point for Sbrt. Here you can see in the axial T2 view what things looked like. So this patient had surgery for this in part to stabilize the spine, and that's what these things here are, the rods that were used to stabilize the spine. But you see, in the process of having a surgery, he developed a CSF leak. And this is a huge pocket of CSF, which has actually crushed the thecal sac, which is this T-shaped thing anterior to the CSF. So now treating this patient with Sbrt would be very hard, because it's hard to tell what's at risk when there's a huge CSF leak in the back. This is just what it looked like in the post-op setting. So that's just to say that sometimes after surgery, it's very challenging to deliver Sbrt. The other thing that can make things challenging is that even when a surgery is done with titanium, it causes metal artifact on an MRI. And if you work with good radiologists, they are able to reduce that metal artifact, as you see here on the right and left images. This is the same patient, same slice, one without metal artifact reduction, one with. You can see that it can be done, but if you don't have metal artifact reduction, it's basically impossible, because you can't see where the spinal cord is. And you need to see precisely where the spinal cord is to deliver Sbrt effectively. This is just to show a more successful case of postoperative Sbrt. This is a patient with an L5 tumor. Here, the GTV typically would include wherever tumor is left behind, but the CTV is defined as wherever the tumor was before the surgery. So that's really, it's sort of somewhat simple in that way, in that when I see a spine Sbrt case in the postoperative setting, I contour them basically as if they never had surgery. So my CTV is exactly the same as it would have been before the surgery, because these resections are never gross total resections. There's always lots of microscopic disease left behind, and you can't see whatever disease that is left behind very clearly anyway. So because in this case, the tumor was in the vertebral body and in the on the left here in the pedicle, in the post-op setting, the CTV included the bilateral pedicles and lamina, and then the transverse process on this side. And the PTV was as before. And because this is below the level of the spinal cord, I used the thecal sac as the organ at risk, and or the cauda equina itself. I also contour the spinal nerves when I'm near the brachial plexus or lumbosacral plexus, because those are also organs at risk. And then the plan evaluation is very similar as before. You're looking at dose to the thecal sac, the cauda equina, bowel, esophagus, etc., and looking for coverage of your CTV and PTV. And if you want sort of guidelines to know what kind of coverage you should be expecting, you can look at the prior Sbrt trials that were performed either by RTOG or the CCTG SC24, whereby generally you're expecting coverage that's less than you would expect with a typical radiation plan because of the spinal cord. So we might shoot for, say, 80% coverage of the CTV instead of your typical 95% coverage. So I just want to reiterate that the challenge of Sbrt is that the dose that you need to control the tumor is more than what the spinal cord can tolerate. And it's that balance that makes things challenging. The dose constraints we use are not set in stone. Different centers use different dose constraints. Obviously, it matters how many fractions you're using. And that depends upon how big the lesion is, how many vertebral bodies you're trying to treat at a single time. It also depends on what type of technology you're using. If you have something to monitor intrafraction motion, then you might use a higher constraint. And also how much risk you are willing to take, how conservative you are, your institution is. So all these things matter. There are dose constraints, again, that you can use from published trials or from, what people use at other centers, but ultimately it's not as straightforward as it might be in another setting because it depends on all these factors, mainly the technology. And then of course you need constraints for the esophagus. If you're treating in the thoracic spine, also the proximal bronchus and trachea, the kidneys, the bowel, the spinal nerves, the mucosa, as I said before, the skin. You need constraints for all these, but again, in reality, it's usually the spinal cord and the esophagus that are the two biggest issues. I wanted to just briefly show you some examples of when tumors fail. I would say in my own practice, the rate of local failure following Sbrt, and this is with a median follow-up of say 1.5 years or 2 years, is probably it's about, I think, about 7% or so. So it's pretty low, but we do have patients that fail. And so this patient, for example, had hepatocellular carcinoma. I treated this, relatively small looking tumor here, 24 gray and 2 fractions, and with Sbrt, huge, pretty high dose of radiotherapy. The tumor was very easy to treat. The only real organ at risk was the esophagus, which was anterior to it. And yet it failed 9 months later. And you can see that very clearly on these sagittal MRIs, where initially the tumor only occupied the first anterior half of the vertebral body, and then it went on to involve the entire vertebral body. It grew through it. And this was a biopsy-proven failure. This is another example of a terrible local failure after Sbrt. This patient had colorectal cancer. I treated him with 24 gray and 2 fractions. The tumor was fairly well confined here in the vertebral body. It looked like an easy target. It was between both kidneys, but you can see the plan nicely spared both those kidneys, and yet the tumor grew despite that. So this is to say that local failures do occur. Cancer is cancer. This is renal cell carcinoma, another difficult tumor, another very radio-insensitive tumor. The original tumor was growing out of this vertebral body anteriorly, but was not at all in the canal. And I treated it. And 2 years later, it had completely overtaken the canal and was growing right into the spinal canal, causing deviation of the spinal cord. This is more of a general slide, just to say, like, the algorithm that I use when I'm presented with a patient with back pain or neurologic deficit. So if I'm on call, or if I get a consult and I'm told, well, I have a patient with back pain, or I have a patient who's got a spine tumor and they've got some neurologic deficit or radicular pain, the first thing, of course, I always ask for is imaging, preferably a spine MRI. I usually get the whole spine because it doesn't take that much longer to get a whole spine MRI as compared to a limited spine MRI. And then I know, I have a better picture of the full extent of their disease. And then it can go one of 3 ways. If the patient has cord compression, and that generally means like a neurologic deficit because of cord compression, or if their spine is very unstable, I call a spine surgeon. And if the spine surgeon agrees to operate, hopefully they'll decompress the spine, and after that they can get radiation, either with Sbrt or conventional radiotherapy, depending on what's appropriate. On the other hand, if upon evaluation of the patient, they don't have cord compression or their spine is not completely unstable, but they have mechanical pain, then what I aim to do is give them radiation in combination with either some type of stabilization procedure, meaning a surgery, or perhaps augmentation, meaning vertebroplasty or kyphoplasty. And I combine that with either conventional radiotherapy, again, or Sbrt, whatever is appropriate. And finally, if I get this phone call and I get the spine MRI and the patient does not have any cord compression and they don't have any mechanical pain, well, then it's easy. I just give radiation, often with Sbrt, sometimes with conventional radiotherapy, and I consider that the best treatment. So that's just a sort of an overview of the way that I think about my patients. So in summary then, Sbrt probably results in better local control. That's not proven, but it seems it's very clear from retrospective evidence that that is the case. And now we have prospective evidence, which I'll show in the next couple of slides, that it results in better pain control. But patient selection is the hard part for spine Sbrt. It can be a challenge to know who is going to really benefit from this. And generally, we establish this through a multi-disciplinary approach. So just a few words, SC24 was a trial that was run from Canada, from one of our colleagues, and it was a randomized trial which treated patients with painful spine tumors with either conventional radiotherapy, 20 gray and 5 fractions, or Sbrt. And this was presented at ASTRO last year and then in Lancet Oncology this past summer. It was a positive result. The primary outcome for this trial was pain control, complete pain response. And I won't go too far into it, but the eligibility criteria were basically that you had a metastasis to the spine that was causing pain, whereby you didn't require surgery, whereby no more than 3 vertebral bodies were involved in a contiguous way. And then you got one of these 2 types of radiotherapy, and they found that about twice as many patients had a complete pain response after Sbrt as compared to conventional radiotherapy. So this was, again, a positive trial. Now, they have not published the results of local control yet, but that's hopefully forthcoming, but we know at least that pain control is now proven to be better with Sbrt. So with that, I'll conclude, and I'll welcome any questions. I think I hope that that was informative and helpful and useful and interesting. And again, I really thank you for inviting me to speak this evening. And I'm happy to answer any questions you have about what I've presented or anything about Sbrt in general. Thank you.
Thank you so much, Dr. David, for your very comprehensive review. And of course, we have some questions here from the people listening to your talk. The first one, what do you recommend to reduce variability in the contouring of spinal metastasis, despite contouring guidelines or fusion with MRI or PET, or some tool for autodelineation? What could you tell us?
Well, I think that it requires a lot of practice, to be honest, because you learn over time things such as what is possible? Like, what is my radiation planner going to be able to achieve with these contours? So that's one thing. I think you learn a lot over time. Your ability to interpret MRI imaging improves with experience. I personally did not have much experience with evaluating spine MRIs when I started. So I think that is an important thing. Now, I'll say that when I started, I followed the contouring guidelines very rigidly because I didn't know any better, and I wanted to do what was, regarded as the right way to do it. I will say that over time, I have become a little less rigid. So particularly in cases where I'm giving reirradiation, or in cases where including more of the vertebral body will cause more toxicity or is problematic in some way, I may not always follow the guidelines exactly, but generally I do. And the reason I do is because I'm trying to learn from my experience. And if I do it the same way every time, well, then over time, hopefully I'll be able to learn from that. And I'll say that I've had I have a very low rate of local failures over time, which to me means that I'm probably the guidelines are good. And when you do have a local failure, it's usually something that you probably couldn't have done anything about. It's just that you gave it as much radiation as you could possibly give, and the tumor still grew. So unfortunately that happens. But, I guess it answered your question. It's just, it's really practice. I think studying, going over MRIs with a neuroradiologist, I think could be helpful to learn what they know about things. Talking to spine surgeons can be helpful to get their take on things, because, the spine surgeons actually can see with their own eyes what the disease looks like. So I find that helpful sometimes. But I'll say that it's practice. It's once you develop a good relationship with other physicians, who they'll continue to refer to you, and you'll get more and you'll just get more and more practice. The other thing I should say is that I follow all my patients pretty rigorously. So I see patients every 3 or 4 months after I treat them regularly with an MRI, and to ask them how they're feeling. So I try to learn in that way, and I try to study the MRIs afterwards. So if there is a failure, I can say, oh, okay, so that patient failed over here and I didn't cover that. Or, I didn't talk about this, but another place where I often worry about failure is in the epidural space. And so how much additional epidural space do you treat? Usually I try to treat about 5 millimeters beyond where I see gross disease. But, again, it's practice. It's learning what kind of tumors are more likely to fail. This thing of like sarcomas being radioresistant, et cetera. I think you can read about it, but you have to sort of learn you have to just learn through experience. That's my thought.
Okay. Thank you. Another question, what do you think about separation surgery on those cases where there is a spinal cord compression and you want to go with Sbrt?
I think it can be very helpful. My feelings about spine separation surgery have sort of changed over time. I used to think that the advantage of separation surgery was, so I would see a patient, and so separation surgery, just to say, is when a patient has epidural disease, a surgeon can do a sort of a minimal operation where they remove the tumor in the epidural space and decompress the cord, but they don't try to remove all the tumor, and they don't necessarily stabilize the spine with rods and screws. So their procedure is as minimal as possible, just to create space between the tumor and the spinal cord, so you can deliver as much dose as possible. So I think that that can be very useful. I think sometimes it can create problems, even though it's a minimal surgery. Sometimes there are bad outcomes. There can be bleeding, there can be CSF leaks, there can be postoperative seromas, and sometimes those make things worse than it was before the surgery. So that's going to happen. But I think that in today's age, because many of the targeted therapies and immunotherapies we have are so good, if a surgeon can help you to debulk the tumor and just remove some of that tumor, and you can get a good dose of radiation in, you're most likely going to control that tumor for the rest of the patient's life. Whereas if there's particularly if it's a radio-insensitive tumor and there's a high degree of epidural tumor, you're never going to be able to control that in the long run. You just can't. Like that, you can't, because of the fact that you have to spare the spinal cord, that tumor probably won't be controlled and the patient will get into trouble. Now, it may be 2 years after you treat them, but eventually that will be a problem. So I think separation surgery is most useful for patients who, say they're at the beginning of their cancer diagnosis, or they have a type of cancer for which there are very good treatments, EGFR mutant non-small cell lung cancer, or ALK positive non-small cell lung cancer, or renal cell carcinoma. Those are patients where, or even melanoma, those are patients where I sort of think about involving surgeons more readily. If there's a small degree of epidural disease, I'd rather just treat it myself, because I think I can do is just as good a job. So it's not straightforward. Again, it's experience. It really depends on the surgeon. It's some surgeons are just better than others. So it depends on who you're working with too.
Okay. The next one, have you seen any change in the dosimetry with the vertebroplasty material?
No, I haven't. And I think that now, on the subject of vertebroplasty, so what I will say is that vertebroplasty, if you see a patient and you say, well, this patient needs both vertebroplasty and radiation, it probably doesn't matter what order you do it in. They can have their vertebroplasty first and then the radiation, or vice versa. I think either is fine. I think oftentimes I would prefer to do the radiation first, again, just because things are more pristine, and sometimes the injection of cement can move tumor posteriorly, and that obviously is not good. But usually if the interventionalist is good, that won't happen. And I don't think there's any evidence that the cement that they use, the epoxy, it affects dosimetry, and I don't worry about that at all. I don't worry about metal either, for that matter. I've never, I've not seen any instances in which a patient had toxicity because they had, cement or titanium in their back. So I don't worry about it.
Okay, thank you. And do you have any experience with the abscopal effect in spine Sbrt?
I can't say that I have, no. I think that if the abscopal effect is real, then I think SBRT would work just as well as any other type of SBRT in order to invoke it. But I can't think of any examples of that. I mean, I think the challenge with the abscopal effect is that you never know for certain whether or not it was really the radiation that helped, because I think in my experience with immunotherapy, if the patient tolerates immunotherapy well, and the cancer is the right kind of cancer and it's the right kind of patient, immunotherapy can work really, really well. And some patients, immunotherapy is too toxic, and in other patients, it doesn't work at all. And I'm not convinced, to be honest, yet that radiation makes immunotherapy or causes other abscopal effects. To me, I think the jury is still out. So I can't say that that I've really seen it.
Okay, and regarding the response evaluation, there are some cases with pseudoprogression, like happens in the brain. What can you tell us?
Oh, So people have described pseudo-progression following spine Sbrt. And I will say this, much like the brain, and you may, all have experienced this before. So I would say that at least 50% of the time after I radiate something, I get a follow-up imaging and the report comes back and it says tumor progression. And I just take it away and I just look at the image myself. And it's almost never actual tumor progression because, I think for someone who is not accustomed to looking at something after it's been radiated, they see changes and they figure, oh, it's tumor progression, but it almost never is. Now, I'll tell you, so many things can happen after you irradiate a vertebral body with spine Sbrt. You can cause a fracture, and that can be interpreted as progression. That's actually pretty uncommon. You can get fractures, but usually the fracture is caused by the fact that there was a lytic tumor to begin with, and you killed that tumor and the bone collapsed or something of that nature. That's not to say that spine Sbrt can't cause vertebral body compression fractures. It can, but those, in my experience, aren't really that common, and it's usually a very late effect. At any rate, sometimes you see a fracture and that may be interpreted as progression. The most common thing you see is that, so when you irradiate the spinal column, many of us have seen before on MRI that the bone marrow will look different on MRI because the bone marrow elements are replaced with fat. And so like on a T1 weighted MRI scan of the spine on a sagittal image, it looks very bright where you were radiated. And conversely, for some reason with Sbrt, what you can sometimes see is that the bone marrow gets more dark where you treated. And so tumor looks dark, and the radiation changes also look dark on a T1 weighted MRI. And so it's very hard to tell sometimes whether or not changes, say, in the adjacent bone are caused by the radiation or from tumor progression. So again, it's experience. So I've learned over time that those changes are almost always radiation. If you treat something with a high dose of radiation from Sbrt, the likelihood of progression is very low. So those changes are most likely not tumor progression. The other thing I look at is that change in the signal in the bone marrow very linear? If it's very linear, that suggests it's from the radiation and not tumor progression because it's matching the isodose. Tumors in the spinal cord almost never travel from one vertebral body to another. Now you can get two vertebral bodies next to each other that are involved, but it almost never spreads contiguously because of the disc is very thick and tumor can't go through it. And they're not connected in any other way. There's no bone marrow connecting them. So sometimes when I treat something, I'll get a report back and it says, well, now the next bone up is becoming involved. And I go, that doesn't make sense. It's not anatomically, that can't happen. That's just the radiation line. And if you look, you'll see it's a perfectly straight line and it's just the radiation changes. So in answer to the question, yes, you can see pseudo progression or other changes that are not tumor progression. And you just have to have patience and follow things over time and also have confidence that most likely it's not tumor progression because most tumors are killed very effectively by Sbrt. Rarely they're not, but when they're not, you can usually tell. And it can be stressful in the beginning and it can be stressful for patients. But, I tell my patients, look, I don't think this is tumor progression, and we're just going to watch this and it's going to be okay. In the beginning of my practice, it was very stressful. Now it's thankfully less stressful.
Okay, so thank you so much. There are more questions, but we are running out of time. So thank you very much for your participation, for being with us and show us your experience.
Well, thank you very much again for having me. And if anybody wants to ask me additional questions, please feel free to email me. I can share my email with you or Carla or with Enrique Gutierrez, our excellent fellow who's working with us. And I'm happy to answer any questions anybody has.
Thank you. Entonces, por favor, si tienen alguna pregunta, con gusto se les va a proporcionar su email para que se las puedan hacer directamente. Agradecemos a todos por su presencia y por su participación. Realmente mucha audiencia, más de 250 asistentes, no solo de México, sino también de Centro y Sudamérica. Agradecemos su presencia en esta sesión académica de Somera. Buenas noches. Thank you, Dr. David.
Buenas noches.
Buenas noches.